right, welcome everybody. Thanks for being here. Today we've got our pediatric medical shared decision-making frameworks for families and providers. My name is Mindy Dokis, and I work at Utah State's Institute for Disability Research, Policy, and Practice, also known as the IDRPP. I would like to welcome you all to our webinar today. The webinar was organized by the Multicultural Disability Network and Training project that I work on. We seek community integration and inclusion of people with disabilities from multicultural backgrounds. The intersectionality of disability and diversity includes many factors such as race and ethnicity, age, rural or frontier geographies, gender and gender identification, health literacy, SES, among other cultural elements that creates a complex context that needs expanded conversations and learning opportunities, such as this webinar presentation. As part of the MultiNet work we have developed at the IDRPP, we have other products, that I invite you to look at. I will put a link in the chat as soon as I'm done talking here, so you can check that out. Today we have the privilege to have Emmie Gardner and Rylee Kiernan. Is that how you say your name? I should have asked before.
Yeah.
Thank you. Who are trainees at the Utah Regional Leadership Education in Neurodevelopmental Disabilities. In this program, professionals, graduate students, and community members are trained to move beyond discipline boundaries to provide optimal services to children with special healthcare needs within a family-centered, culturally responsive framework. So they today will be presenting about barriers and ways to overcome those barriers to increase communication around medical shared decision-making. And I want to give, before you get started, I'll give you guys just a minute or two to introduce yourselves. And then we'll get started. First, I have a few ground rules. I would like to invite the audience to introduce yourselves briefly in the chat so we can know a little bit about you, including your name, your organization that you represent, and your role there. Please keep your mic muted during the presentation. We're here to discuss, not to debate or argue. Any discussion should be focused, and please avoid deviated conversation. Keep an open mind and be open to learning something new. Be respectful of others. Listening is as important as talking, and avoiding making assumptions. And if you have questions, you feel free to put those in the chat as well. Or there are times throughout the presentation that we'll have time for questions as well. So we'd love to hear your questions. And anyway, I'll pass the time on to Emmie and Rylee.
Hey, I just saw someone, thank you for people from Boston from dialing in. That's super awesome. Hi, my name is Emmie Gardner. I am a clinical social worker by training, spent nearly 30 years at our local children's hospital here in Salt Lake. I currently am the CEO for Holy Cross Ministries, which is a local social service agency here in Utah that really supports the immigrant and refugee population. So I've sort of taken my medical and social work background and kind of incorporated it with that intersectionality of culture, which is so much of what LEND is about and why I'm so passionate about this idea of shared decision-making. Take it away, Rylee.
Sorry, I should have switched slides earlier. I'm Rylee Kiernan. I'm a special education teacher at a Title I school in Ogden, Utah, but I'm also a PhD student at the University of Idaho. And this was my first year in my PhD program, but this was a great program the URLEND program was great for us to be able to work with a bunch of different disciplines that we wouldn't have been able to otherwise and create this great wealth of knowledge that we're excited to share with you today.
Yeah, so Rylee and I will be running through these slides with you all, but we just wanted to highlight the rest of our amazing team. We had a really fun leadership team, and part of this LEND training that we did, we had to do a project, and our shared decision-making echo is that project. So on the call, we do have Amy Reiser, who obviously her background is in public administration and public health, and she kept us so freaking organized. It was amazing. And Jessie Allery, who is, a behavioral specialist, is working with families day in and day out in North Dakota. We had an audiologist, Elena, who was just absolutely amazing. Who comes not only with her clinical background in audiology, but lived experience as she and her partner and her husband had adopted special needs kids. And then Abby Norton, who was, again, another PhD psychology faculty that was specializing for training in this as well. So again, this is a product of all of our work, but we just kind of take turns doing that presentation. And then we have to always do an amazing shout out for those of you that obviously know MoldyNet. Many of you probably already know Dr. Ortiz. He's just an amazing human being and just is so passionate about this URLEND, our Utah Regional Leadership in Neurodevelopmental and Related Disabilities. And he really has worked very closely. I've only been at this organization for going on 6 years, but he's worked for many years beyond that with our organization because we run a support group called NEF, Niños Especiales Familias Fuertes, and it is for special needs families that are culturally diverse. So again, we just want to do a shout out, obviously, to MoldyNet and also to the Family Health Information Centers for helping us get this information out to everybody. And we appreciate all of you providers. And as Rylee said, we love the interdisciplinary nature of it because, again, with disabilities, we believe it really takes a village. So our goal for you guys today is to really help provide you with a framework, not only for providers, but also for caregivers of children and youth with special healthcare needs, with the goal really to kind of find that common ground, encourage shared decision-making, and kind of move beyond a model of, okay, I'm the expert, I've got the background in training, so I'm going to tell you what to do, that kind of paternalistic approach, to really more this collaborative approach of realizing providers have gifts and talents and expertise to give. But again, families know their children best, and they have that lived experience that together, hopefully we can make the best kind of care plans for those special kiddos. So our objectives are two, right? We want to increase awareness for the communication prompts that can promote cultural curiosity and facilitate responsive communication. And we consciously use that term cultural curiosity because really no one of us can be a cultural expert, no matter how much book work we learn. You know, the reality is the person sitting in front of us knows their lived experience and their culture and their background and their spirituality and how that relates to them best. So it really is, how do we elicit that information so that that can be incorporated in the care planning? The second objective, sorry, Rylee, can we go back to two? Sorry,
Yes, sorry.
Rambling too quick. The second one is increasing the familiarity with circumstances that call for a modified communication strategy. So understanding that for many cultures coming here, they will defer to an authority figure, right? So that you may not get as much communication or response unless you really question and elicit that. They're not going to just proactively share that information, and to be aware of things like that cultural change or socioeconomic status, or again, limited literacy as well, that really can impact what folks know and how they're participating in that care planning process. So then the other two objectives we have, of course, because we're overachievers for you guys, is increasing awareness of common barriers, just so that those can maybe be triggers to help you be a little more conscientious or sensitive to what is the family constellation I'm dealing with. And then the last objective is really looking at anything we can do to help you minimize obstacles and really increase that family participation in the treatment decisions, because our firm belief is, if you build that decision, you have them empowered in creating that treatment plan, there's going to probably be better compliance. Okay, so let's talk about the what and why of shared decision making. So really, the Health Services and Resource Administration back in 22 identified 6 major components that are really critical when you're working with children and youth with special healthcare needs. And we're just going to walk through those really quickly. So, I mean, they are that children are screened early and continuously for special healthcare needs. We know, obviously, from the research that there are times where we see BIPOC kids are screened at later dates than maybe Anglo or middle class or upper middle class families. We know families of children with special healthcare needs. It's critical that they are partners in the decision making, like we said before, not just kind of receivers and implementers. Community-based services are organized so that families can use them easily, and that's navigating healthcare, we all know, is super complicated. And, it gets amped up when you have a child with special healthcare needs. Obviously, that idea of medical home is really a way that we create that village for these families with their special needs kiddos. And then families, this is again at times very much a barrier, number 5, where families have adequate insurance and funding to cover services. We know that that isn't always the case in the communities we serve. And so what other opportunities are there to help and support folks so that insurance doesn't become a barrier to accessing services? And then lastly, that, families receive the services necessary to make transitions into adulthood and into adult health care, because it's, pediatrics is amazing and wonderful. And like I said, I spent 30 years in it. I love it. But it's not like we have a young adult practice, right? People either go to family medicine or they go to internal med, and internal med tends to be more geriatric. And so it's that transition to adult healthcare can sometimes be a stumbling block and a challenge. And we realize that, again, the research is showing that only 14%, a little over 14% of families with children with special healthcare needs are actually receiving all 6 of these components in their care process now. So another reason why we wanted to kind of focus on this. So one of the other pieces that we think is super important is this idea that quality of life is key, right? And again, I say that as a person who also has done a lot of palliative care and hospice work. But again, I think healthcare systems, I spent 15 years in cancer care, and sometimes we would say just because we can doesn't mean we should, because there were times where we would also say that there are worse things than death, just in terms of the treatments that we provide, right? So I think that key is focusing on quality of life for as long as a child has life, and the well-being, not only for the child, but for the family, is really critical. And when we think of quality of life, it's a variety of variables, right? So it is about the child's autonomy, their dignity, their independence, what sort of spiritual construct they're understanding this condition in, what kind of cultural mores or value systems play into that, relationships amongst family members, amongst the community, what are the family's coping skills, as well as what is the quality of the caregiving and what is that caregiving burden as well. So just really kind of always thinking, how do we balance? Here's the amazing, incredible, cool medical interventions we can do, but how does that balance, within the quality of life of the child that's sitting in front of us, right? So, I mean, I love this visual just because I can tell you, working at Primary Children's here in Salt Lake, I mean, this was every family we dealt with, right? I mean, so when you think of the complexity of families, right, and the various, even just within the color scopes, the color differentiations of this, right? Like all the issues and challenges as you have a special needs child and what you're dealing with within school. And obviously that's Rylee's amazing expertise in that piece. But, what are we doing with kind of developmental assessments and how long and wait lists are now to make that happen? Health is super complicated because they start with a pediatrician and then get referred to other developmental pediatricians, other specialties, PTOT, speech, a variety of things. What is their support system like, right? What are the legal and sort of financial contributions? I mean, like when you think about, it's like always that tip of the iceberg. You have this child and family in front of you, and there's so much else going on. But it's again trying to just put ourselves in their shoes of what are the various balls that they're just trying to balance and juggle every day. So, we want to talk about shared decision making, and we really wanted to define it so that we're kind of all coming from the same place. And we really want to talk about that being a collaborative process between the providers, the patients, and including that, like we said, that exchange of information and treatment options that not only take into account the patient's medical needs, but they look at the patient and family needs, they look at their belief systems, their values, their goals, and their preferences. And when you put that all together, hopefully we come up with, best treatment plan that's individualized to a patient and a family. So when we look at shared decision making, though, again, research shows us that there are disparities in shared decision making, right? White non-Hispanic families tend to to say that there are higher rates of shared decision making. I mean, you're pushing 86% there. English speaking families, again, close to 85% meeting that criteria that's defined about shared decision making. But again, when we look at culturally diverse families, and Utah is becoming a more culturally diverse state, right? And obviously other places where you all are dialing in from, I'm sure are feeling that same in-migration of new arrivals. And so non-white families, again, from any cultural background, right? 77% of Hispanic families, feel that they're participating in a shared decision making. Only 72% of Indigenous or Alaska Natives felt that they met that criteria. Again, but then non-English speaking families, it's dropping already down to like under 70%, feeling like that criteria is being met. So one of the things that we wanted to talk about too is what are the various individual components of shared decision making. And so, we wanted to talk about, like, again, when we were trying to survey folks to see kind of what their sense was, and doctors working with parents, to decide together about healthcare treatment and treatment options. When it's English speaking, you look at that again, 70% versus other languages. It's kind of hard. Sometimes things get lost in translation with interpretation and such. We're not even at 60% there, right, where they feel like they're deciding together. Education levels do have a huge bearing as well, right? Where, when you look at only 59% having less than a high school education, 67% maybe at high school. Again, it goes up as you see folks with college or higher education. The other piece that I would layer on that, just given the work I do now, is it also gets complicated when you're dealing with folks with a cultural difference and not knowing whether or not they're even literate in their own native language, let alone, learning English. So again, the next component of doctors discussing the range of healthcare treatment options. When the primary household language is English, you see that people feel like, that the 68% are feeling like we're in a shared decision-making mode versus other languages other than English, we're barely at a little over just 50%, so half and half feeling like they're really having that kind of collaborative conversation, right? And again, tying into what does that mean in terms of education? Again, similar things as education goes up. Again, people feel a little more empowered, probably feel a little more knowledgeable, less threatened, they're ready to sort of advocate. And finally, doctors make it easy for parents to raise concerns or disagree with recommendations. Again, English speaking folks tend to feel that's definitely a possibility, almost 70% there. But then non-English speakers, again, we're just a little over 50-50. So thinking of that as providers, maybe going into sessions, realizing that people may already come with that sense or that bias of, I'm just going to be here to listen to what the doctor tells me I need to do, and what you can do to really elicit and pull out that collaboration, to give them permission, right? And give them that space and grace to really engage in the conversation. So we also wanted to talk about how this process can really support not just better conversations, but it leads to better informed decision making that will match what matters most to patients. Just a 30-second aside, when I first moved to Utah, I was working with the Southeast Asian refugees, and I remember at one point, bringing them to a facility, and just the sort of smile and nod, and my interpreter was like, well, they're just providing deference to you as the person that's working with them. That doesn't mean they agree. And so I think sometimes in that lack of communication, we can seem to think that that folks are agreeing with us, when in reality they're not, kind of they're just deferring to our authority figures, right? So we want to make sure that we can get that input about what matters most to them. So again, what we see in the research is, the more that we can promote bidirectional clinical communication, it also will improve parental knowledge and satisfaction. It will lead to increased adherence to treatment plans, because, they have a sense of ownership of having created this. It enhances patient engagement and empowerment, and it really leads to positive health outcomes, right? So for us, that's why we really feel this is kind of the modality that hopefully gives you a construct to help get what we know you want to, the best for your patients. So, just looking at this slide, we wanted to talk a little bit about kind of various roles, patient and family side, but again, acknowledging that piece of patients and families, they are the expert about their child's unique needs and their holistic quality of life, right? And so you take that and you marry it with the provider who is familiar with the conditions and the treatment options that the child has, right? But then, you again look at patients and families. They develop knowledge over time and hopefully can convey that knowledge and their lived expertise with the providers. And so that can get incorporated into a treatment plan. We also want to help empower families so that they can advocate for the care that they believe their child needs. And we also want them to be able to speak to what is feasible and reasonable regarding treatment plans. And again, this is that piece of, I mean, I love doing home visits because when you have someone come to you at the hospital, it's one thing, but you see them in their world, in their space, and it gives a whole nother sense of what is feasible and reasonable based on their circumstances. Because many families are very proud and very humble and are not going to share with you that they can't do that piece because simple examples, why is the insulin not working for the diabetic kid? Well, the refrigerator isn't working, so they're not keeping it cold, that kind of thing. So, and on the provider side, in addition to, being those experts about the conditions and the treatment options for the condition that you see in front of you. I mean, it clearly is being able to convey that information, without a bias, just in an objective way that's showing both the benefits, but the potential side effects or burdens of those choices, right? So that families can truly make that informed decision. Again, trying to elicit as much as you can the parents' opportunity to engage in questions about the treatments or understanding about it, ideas of how might that work within their family setting. Always kind of asking and questioning for clarification and misunderstandings, because again, that I think happens a lot, especially with diverse cultures. And then, and it's not intentional, and it's not, a picking on providers and doctors. It really is just that miscommunication of language, right? And so just always ensuring we're clear on what we're saying and that they have an understanding of what we've said. And then truly ensuring that a treatment plan is agreed upon and implemented with fidelity in a way that the family says, I can do this, or giving them that, again, that space and grace to say, I can do this and this, but I can't do that part. And what's that going to mean for my kid's care? And so that they're not feeling like, oh my gosh, they're a failure to their kid, but they're just wanting to honestly share with you what's possible given their circumstances. So we're going to stop there. I've been blathering on a lot. I apologize, but we just wanted to get through these things for you. But any questions on what we've talked about so far, just in the general concept of shared decision making and what's foundational in making that happen? Anything in the chat, Mindy?
No, I haven't seen any questions in the chat yet. If anybody has a question, like I said, feel free to throw it in the chat, or right now you could even unmute and talk to us if you'd like.
Okay, we'll keep rolling then. How about that? Okay. So then we want to talk a bit about addressing barriers. And so when we talk about barriers, what we mean is system barriers. Again, health system, when you think about navigating the complexity of health system, cultural awareness, cultural curiosity, as well as patient values. Any one of those can present as a barrier, but a barrier can also be an opportunity. So we thought, I don't know, we're kind of, like I said, we wanted to give people frameworks that may help you kind of think through this. So, there is a nationally, a research-based model called LEARN, which again, for the audience today as providers, is that idea of being able to listen, explain, acknowledge, recommend, and negotiate, right? And so that acronym, I think, works really well. As we were looking at the research, what we realized is there really wasn't a model that empowered families. And so, kudos to our team for coming up with this SLATE model, right? Which is this idea of sharing, again, values and treatment, listening, assessing, talking, and executing the care plan. So we're hoping that, both the LEARN framework for you all as providers is critical in helping you keep to that full scope of what's involved in shared decision making to make it go well. But also we wanted to share with you that, hey, if families come to you with this, kind of their own acronym of, I want to share with you this piece, I will listen to the information you provide. I want to, assess and discuss kind of resources and limitations around the treatment plan, talk and reach mutual decisions, to be able to successfully execute it. You see it from kind of both perspectives, right? Because again, it's a team caring for this kiddo. So hope you can see those frameworks, see if that would kind of resonate or at least work in your respective practices. And then, do we go backwards, Rylee?
No, sorry, this is just highlighting that now we're going into systems.
So sorry. So now let's talk system barriers. My apologies. Yeah. So I think when we look at systems, you know, I think lack of consistency in information, lack of information shared amongst providers. You know, you guys know that. I mean, practices are different, and one provider might make one area of needs have like a real high priority, while another might, you know, either belittle that same topic or have a different one. And when you think about that, especially families with kids with special healthcare needs, they're probably again wanting to kind of do what the providers say, but when they see different subspecialties, you know, no harm, no foul. Every specialty has their focus, right? And they will see that as that priority. But it's again realizing let's try not to send those mixed messages or confounding messages to families of, but you know, my neurologist is saying this, but the cardiologist is saying this, but the PTOT is saying this, but the audio, you know, it's complicated when the families are like, how do I execute on all of these when they may be differing concepts, right? So and especially for families, again, as we learned, based on education background and such, trying to integrate all of that gets really complicated. So, you know, if we can come up with that sort of united front in terms of a care plan, that is going to hopefully minimize some of those system barriers as families are navigating between a variety of providers. And then, you know, again, like we said, time and frequency, other system level barriers, just in terms of not even just focus of subspecialty training, but time and frequency between provider and patient. We get that you guys are all incredibly busy, you know, and that's kind of a system issue, you know, that you only have so much time with each family, right? And especially when you're trying to have these discussions, they tend to take more time. And then when you layer on interpretation, that adds time in addition, right? You know, like we were just discussing before, that idea of the multidisciplinary communication across the different subspecialty providers. Medical interpretation, I think one of the other things we had a question added to our registration. I think that just want to make sure that people understand. I mean, like I said, at primary, I think we had like 48 different languages, you know, and we had X amount of folks that had in-person interpretation versus when we use kind of tablets, you know, or iPads. But I think the other piece we have to always remember too is it's not just language, but we have to think of sign language as well, and ASL or whatever would be the best modality that we're really integrating so that that person's voice and their family's voice can be heard, right? So think not only language and interpretation, but hopefully many of you providers have that access to ASL as well. And then again, I can't speak to your own practices, but again, just knowing that adequate time for appointments when you know this may be a more complicated conversation. The other piece that we see as a barrier many times for families is that issue of, and I think COVID has kind of helped a bit in that with telemedicine, but challenges with transportation, especially for lower SES or culturally diverse folks, as well as childcare. I mean, I remember families coming into primary, you know, with their child who's the identified patient, you know, and 3 other kids in tow and a baby in a car seat. And again, just really appreciating what it takes for families that are caring for special needs kids to not only care for them, but to help manage everything else in their life too, that those become barriers to them. And they're not problem families that are not showing up. It just may be that they don't have a car ride, you know, to get there. And that's why they miss the appointment, right? And somebody put in the chat, thank you, a barrier I face frequently when visiting families that's that of language. Yeah. Already limited literacy. Yeah, and if the clinic isn't offering interpreter or language line, thank you for going to the appointments with them and providing interpretation. That's amazing. Yeah, and I think, you know, again, I can't speak to different practices, but you would hope that, you know, in this day and age, we are at a place where we realize healthcare is for all in our communities and that we should have those support systems. I mean, maybe it's a funding issue. Don't know why they're not providing medical interpretation, but thank you for sharing that. That is a challenge, and glad you're able to go with them because it's, again, you can't have shared decision making if you're not even speaking a common language, you know. So I think the next one is just questions again through this section. I think, Rylee. Yeah. Sorry, I just grabbed that last one in the chat, Mindy, because it popped up right as I was chatting.
No, you're good. I think that brings up some interesting points too, where she talked about like people that have limited literacy, regardless of like their language, you know, if it's even if some people who are English speakers, if they have limited literacy and then doctors are talking to them and they're not understand. I mean, I've had that experience. I'm in the doctor's office and they're telling me things and I'm like, in English, please. I think you're speaking English, but I'm not understanding any of it. And I think that's something really to think about, simplifying our language, just simplifying our language even before we try to translate into another language is really important.
You're absolutely right, Mindy. I'm remembering a chaplain we had at Primary Children's for years would always be like, oh my God, you guys have so many acronyms and alphabet soup. And like, can we just talk plain language, not medical terminology? And you're like, oh yeah, that's true. Like, but like for us, you live in it day in and day out and you get it. It's like shorthand, but it's like, how do we explain it in a way that it's understandable to the person on the receiving end? Yeah, for sure.
Yeah.
Any other comments, questions before we move to the next section?
Okay, so we're just gonna touch back to these two frameworks. I just wanted to put them in there as we continue to go through the rest of the barriers that we have. So the next barrier is in the realm of cultural awareness. So a family that we interviewed said that they're hoping that their intent comes through as it was conducted in Spanish. So they obviously they're hoping not to lose things, and it's often that like simple conjugations can make things misconstrued, or perhaps you're using like some like verbiage that just doesn't really translate well, and so then we're struggling to really get to understand and get to the point and have those good communication skills with each other. So here are some other cultural awareness barriers that we wanted to highlight. So I think number one is clear communication. So knowing how the parent, the patient, and the family prefer to communicate, and lack of cultural knowledge in the patient's native language. Sometimes there are very like similar words that one can be offensive and one is the term that you're trying to use. And you want to make sure that you're communicating well if you are trying to be the person communicating in their language. And you want to make sure if you do have an interpreter that they're actually being able to communicate what is being said between both parties. Next is verbal and nonverbal cues. So I think about this is like a lot of hand movements. How comfortable does the family feel about making eye contact? Is that something that we need to think about before we step into that meeting? Or do they feel comfortable shaking hands? Things like that that can make a big difference in the relationship that you're going to want to build with this family. Conscious and unconscious biases. Kind of going along with that is power dynamics. So many culturally diverse patients will defer to the provider. And then they also may defer to like the father head of household figure if he is in that room as well. And so the many diverse patients will think, okay, the provider knows what's best. We're going to do what the provider says, but without thinking about kind of like how Emmie said, is this feasible for our family and what we are able to do? They'll just say, oh yes, we can do that. We can do that. And then they leave later and then they're working through some things themselves. And then last is cultural practices and customs. So kind of more going into power imbalances is patients do have the skills and capabilities to be included in decisions about their own or their child's healthcare. But like we said, some cultures tend to defer to the authority. So they just don't want to be viewed as wrong or difficult or belittled or worried that they're being judged. And then going along with that, like I said, some of them choose to defer to the head of the households. And so the provider or the dad may be the person who is having that conversation with the doctor, not involving the other family members who might be the patient or the mother figure that's there. And those things can really offset how we are looking at this as a whole, with everyone trying to equally help the child. What's the child's role? So sometimes we can involve the child depending on what that looks like within the family. So do we think there are cultural implications of asking the child instead of the authority figure? I remember when I was younger and we would go to the doctor, even if I was feeling sick, like I could have definitely answered the question, but I was very nervous to have that conversation with the doctor, saying just something as simple as like, I have a sore throat. And so for children who do have special healthcare needs, I think it can be really empowering for them to be able to have those conversations with their providers, or even just be able to listen and think about like, what does this look like for me? And because as they get older, one of those 6 key aspects was transitioning from childhood to the transition to adulthood care. So if this is a lifelong thing for them, what are we doing when they're younger to help them be an active participant in their treatment decisions? So here are some question prompts that we can help. So we can help from the provider, the doctor, and the patient and family perspective to kind of bridge the gap for cultural awareness. So some things that the providers and doctors can do is, of course, to use plain language, avoid using medical jargon and complex terminology. That's what Mindy and Emmie kind of just discussed, right? As a special education teacher, there are so many complex terms that we use, and I work at a Title I school with a large Hispanic population. So many of the parents don't speak English, and I try to make it as simple and understandable as possible. So when the interpreter comes in, they're not like, okay, what was that again? How can you explain this in another way? And I try to give examples that they can understand in that plain language for them. Balancing, holding space and providing an overview of all the options, and ask the family open-ended questions to gauge their understanding and knowledge of the content. Maybe before you get into it deep, do it at the beginning, after, like before you're talking about treatment options, just talk about what do they know about this? Have you heard of this before? And try to do it non-judgmental is very important. And then the discussion, what the discussion means to them and what their next steps can possibly be in the realm of treatment. And then similarly, for the patient and family, hopefully that they can share with their provider, or as a provider, you can kind of cue these questions to encourage that conversation. So what is important to your family around your treatment outcomes? What options fit in or do not fit in with your values? What are your barriers, challenges, or concerns that you see in these treatment options? And what are the pros and cons of the treatment options with your family's current life? And also kind of how Emmie discussed, it's for a lot of families, they're not going to open up. It's like you have to prod to get them to really share these things. And so if you're a provider that's going to see this family for a while, this can be a really great time to try to build that relationship with them and start really getting to like have that trusting relationship where you know what they're really capable of, and you can continue to build on that throughout your time together seeing the child. Do you guys have any questions around cultural awareness before I move on? Okay, you can always put them in the chat.
Quick question. Sorry,
Yes.
I was a little slow. I was waiting to see if anybody else would jump in, but I'm just curious, as I'm not a service provider myself, but I'm just picturing, situations in which a provider would be trying to get answers to these questions. And I'm thinking about the combination of like having another person in the room that's an interpreter, so they're working through this interpreter, or maybe they're working through, like an iPad or something with the interpreter there. What are do you have any just like basic suggestions to help make that person feel comfortable? Because I think some of the questions that we're having to ask in these situations are invasive or are just uncomfortable, especially with so many people in the room and so much going on. Like what are your suggestions as far as just helping them to feel at ease with you with everything going on?
I think at the beginning, like when you prior to asking these questions, as best as can be like translated, like this is to better the care for you and try to make it the best for not only your child but your family. And once again, like as best as possible, say that this is not any form of judgment. Like we are here for this child, and we want to make sure that this child is getting the best care possible. And to do that, we kind of need the answer to these questions, and maybe these questions come over time, right? And so maybe you're asking 2 questions each time you see the family, and then you're creating like a more full picture as you see them time and time, because we are, as we know, like providers have a smaller period of time to be able to see them. And if the family feels like they're going to a doctor's office just to get questioned for that entire time, it will make them feel uncomfortable. So kind of easing into it, building that relationship, and making the family feel comfortable with you. So if there's things that are relevant in your life that you can share, maybe some experiences that helps them feel like, okay, I am talking to a person, not just someone that's here to get in and out of this room, and that to their next patient could help. Emmie, do you have anything to add?
No, you handled that really well, Rylee. I think the other piece, Mindy, to what you said, and I've heard this like from partner agencies that work like with torture victim refugees of trauma, and like sometimes they've had the challenge that again, cultures are very tight knit in finding an interpreter who may speak that dialect of their African language. Sometimes people are reluctant to share information because then they're worried it will get back to the community. So I think that's just being sensitive to that. And so sometimes families, like they were telling us, would have to say, no, I'll just do the best I can with you, like with Google Translate. I don't want an interpreter. Sometimes honoring and respecting that because that's a request for their privacy.
Yeah, yeah, a fear that maybe a lot of us wouldn't have even thought of. Yeah,
Yeah,
thank you.
I didn't realize that either until, like I said, it's just a neighbor organization. They're now called Thrive. They used to be Utah Health and Human Rights, and they work expressly with folks that are torture survivors and many refugees from various countries. And again, because there's different sort of tribes with unique dialects, there's very limited translation availability, right? So, yeah, that was
Wow.
an aha to me. Yeah.
Yeah. Thank you, guys. Any other questions? Okay.
Okay.
Keep on.
So now into patient values. So once again, this was another family that we talked about, was that what we kind of bolded down here was the key points is that they had to change their employment strategies to accommodate their family's new needs and their family's new needs. Sorry about mumbling. And so I think that's something, like this is just one example, right? We talked to a handful of families, but knowing that people have to adjust so many parts of their life to ensure that they can get what they need to be able to help their child with special healthcare needs and the rest of their family. So some of the barriers in this realm is not knowing what a family's cultural or spiritual values are and its impact on their healthcare decisions, not recognizing what the family can bring to a treatment setting, not understanding how time and financial obligations affect treatment options and feasibility, which I think is a big thing, right? We know that financial obligations can be really daunting for families with children with special healthcare needs and time too, right? What does childcare look like? What does going to our jobs look like? Not knowing what matters to the family. So what are their biggest concerns? What are the long-term family or children goals? Do their goals, the family's goals, differ from what the provider might see as their big goal? Their decision-making process, how how does that dynamic look in that family? And then lastly is the patient and family's levels of knowledge and understanding. So once again, is the information being presented in plain and jargonless language? So here are some questions, once again, to help the provider, and then things that the patient and family can discuss with the provider. So to kind of start from the provider, ask the family to share their understanding of the condition and what this might mean from their cultural or spiritual perspective, and ask about any relevant customs or practices that may influence their treatment options. So do they have special diets that they need to follow? What spiritual and cultural norms can help or might have an influence or an impact on those treatment options that the provider and doctors are going to share? Simultaneously, hopefully the patient and family can discuss with the doctor all about the treatment options. So all of the treatment options and what are the pros and the cons for each of those treatment options. Ask about alternative treatment options and share their preferences for those treatment options, right? I think many times looking at the paternalistic point of medicine, the doctors would share their one treatment option that they thought would be the most conducive in the situation. But I think it's really important when talking with families, and this is all about like making this shared decision together, is going through all of the different options and going down the list and discussing what's best for the child, what's best for the family, how does that fit in from the provider's point of view. The patient and family should share their concerns and limitations about these treatment options. What barriers do they see happening? Will it be too much financially? Will we struggle to get childcare for the rest of the children in the house? Are we far away from a hospital where we can get these treatments done in a normal amount of time? And then the patient and family should share their expectation and their rationale for their treatment decisions that they've discussed. So here are some communication strategies to help providers and families discuss. So number one is to use qualified medical interpreters. And I know that that's not always an option, right? As Emmie discussed, there were 48 different languages at Primary Children's Hospital. So doing your best to use qualified interpreters, especially when there is an option to have a qualified interpreter, but some families might want to use Google Translate or use like a younger sibling that speaks English. Try to use a qualified medical interpreter, but also if the family's not comfortable with that, let them use what they're comfortable with to get that open line of communication flowing. Next is to use plain language and avoid unnecessary or identified jargon. Avoid information overload. As a teacher, I called this like the check for understanding. So every so often stop and say like, okay, do you understand? Do you have any questions? Or if you've gone over something really heavy, you can say, okay, can you explain to me what I just said? In a non-judgmental way, but so then they really know what you guys have been talking about back and forth, because sometimes it can be a lot. And when you're sharing what might be very important or shocking information about their child, it might just go in and out of one ear and out of another. Encourage questions using an open-ended phrase. Use teach back to confirm their understanding. Share credible online sources. And if there are those resources in the language, try to do that as best as possible, or see if the medical interpreters can possibly interpret or translate some of that information prior to when your appointment is. And then once again, different cultures can have very different communication styles. So direct communication, indirect communication, what do those verbal and nonverbal cues look like to you, and what are they communicating? another family said that they would have liked to be told what each option was to be considered. They were told the risks and different treatment options, but not why we might want to pick the different options as it pertains to our child's specific diagnosis or their severity. I'm going to stop right here really quickly in case there are any questions before I move into decision aids.
Not a question, but a comment, Rylee, I would share. And again, providers, you may see this already in your practice. I spent 15 years in cancer care at primary, and we would always talk about families, like you said. I mean, to your point, Rylee, of we're sharing a lot of information about their child. One, again, depending on literacy, depending on comprehension, also depending on life-threatening nature of the condition, right? And so we always kind of would say, a family, maybe here's 10% of what we said, right? And that's okay. It's not a judgment. It's just like, it's okay to repeat it. It's okay to repeat it because each time, hopefully they grasp a little more. So it's again, giving people that permission and that space to kind of just say, okay, I can only grasp this much because it's like overwhelming me, but just, again, realizing that it's complicated. Just again, try to put yourself in their shoes of here you are telling them something about this dear little human that they absolutely love and adore. And so it's just going to all go, right? Yeah.
Mm-hmm. Yeah, absolutely. Okay. So sorry. We're almost done. We're in the home stretch now. So when looking at decision aids, so provide information about options and their associated benefits and harms. Help clarify congruence between decisions and their personal values. Reduce the proportion of undecided participants and have a positive effect on patient-clinician communication. So decision aids can be really beneficial when they're used correctly. So people exposed to decision aids often feel more knowledgeable, better informed, are clearer and better at communicating their values. They have a more active role in decision making, and they state increased accurate risk perceptions. So when discussing treatment goals, right, it's kind of like a cyclical movement that we go through. So number one is to understand the family's treatment goals and choices. Then we encourage expression of concerns and ask those probing open-ended questions, judgmental free. Through asking those questions, we learn more about their barriers around time, resources, their needs, systems, policies, cultural awareness, what their values are, and then we learn about their preferences through this, right? And this might be something that happens very quickly going through these steps, or this might be something that takes a handful of years to get all the way through this. You work through the steps that the family must follow to achieve their treatment goals. And then we understand their preferences, needs, and goals that they can change over time. What might be true for a family in 2024 might not be true for a family that you're still treating in 2027. So the next steps for providers and for families is find one thing that you can do to implement better shared decision making. So as a provider, what could that look like for the next family that you go and see in your practice? Share best techniques with other professionals and families. Be mindful and be more aware about system barriers, cultural awareness, and patient values. And more specifically for providers, reflect on your practice and how you can improve for the population that you serve. And for families, have your family become clear on your goals, values, and treatment outcomes, and for them to know their limitations and be able to comfortably share those limitations with providers. Do we have any questions? Comments?
There was one question in the chat
Yeah.
just a few minutes ago. It says, in my experience, providers seem to be always in a rush. Do they typically have a time limit per visit? I would love for them to just take the time to discuss questions and explain them further. I guess, I don't know if that's a question, but just kind of a comment to think about all this.
I mean, I think just given the time I was at primary and noticing the change over time. And again, like I said, I don't think it's a system issue in all healthcare, right? I think that how do we balance the compassion and the caregiving, which is what I think so many of people went into healthcare for, with the business side of stuff and billable. And and so I think I just noticed that change of, we have KPIs and productivity and billable hours, and that tends to limit that capacity to have conversation. So, I mean, to me, I think that's a system issue in healthcare that um, needs to be addressed, I guess, and changed. But I don't know that that's a simple solution. That there is a simple solution, right? Because I fully believe that any provider really wants to spend the time their patient and family needs to really get what they need happen, but they have these external pressures as well. It's just so hard.
And
Sorry,
can I add?
Rylee, I cut you off. Go ahead, Rylee.
Oh, sorry.
Okay, I was gonna say that, like, even if it might not be possible, when you're calling and scheduling your appointment, you can always call and say, hi, if the normal amount of time that the provider is given for me is 15 minutes, is it possible to make it 30 minutes? And even if they say no, you've done your best to try to get that extra time allotted. And there are some providers that will, or some offices, practices that will allow that, just that extension of time. But I am not in the medical profession, so I don't know what that looks like a billable wise, or what that looks like for the cost the family incurs. But
I was just going to quickly say, when you're using a translator or an interpreter, everything just takes so much longer too. So that, I feel, is like just another barrier on top of all the other barriers you guys have talked about.
okay, we only have 2 minutes left, so I'm not going to go through the case study because I feel like we would just start explaining it and then we wouldn't get very far. But yeah, that's, I think, where we will end. And we really appreciate all you guys coming. And if you guys have any comments, questions, concerns, thoughts, we'd love to hear it. Yeah.
I also just sent out a poll. Everybody hopefully is getting it on your screen. Just to ask about your experience with today's webinar also. But yeah, if as you're answering those questions, if you have any other comments or questions, we would love to hear from you. Anyone on the call?
And Mindy, this is Jessie. I know that there is a list of resources and handouts. Do you have that to share with providers?
I do not. I don't think I do. Is that something that was in the slides that you sent?
No, but I can send it to you.
I didn't realize that there was that, but I will be happy to.
No, good point, Jessie. Thanks for reminding us. Yeah. But maybe, we can send it out to everybody that signed up. Mindy, that'd be great.
Yeah, I will definitely do that. That sounds like a great resource to share.
Perfect. It just has some different visuals and things that might be helpful on both provider and family sides. It would be the same list for the families as well. So.
Okay.
Wonderful. Yeah, it sounds like Mindy, Amy will send those to you. So no worries, Rylee. Yeah, Amy's got it covered. She'll get it to you and then you can get it distributed, Mindy. That'd be great.
Yep. And while everybody's on the call, I'll just mention that this has been recorded and we are going to post the recording to our website. So if any of you want to like refer back, listen to it again, or if you want to share with other people, you think it would be really helpful for someone who wasn't able to join us live, it will be on our YouTube channel and our website, which I posted in the comments earlier, but maybe I will share that link one more time. And then, yeah, if anybody has any other comments or questions, I could just keep talking. We have another webinar coming up tomorrow night for families. So if you or someone in your network could benefit from this very similar discussion, but geared towards the families rather than for providers, That will be tomorrow night at 6. And the link, let me grab that link to our website and you can register for it there. We also have another learning opportunity coming up the week after that. It's a community of practice meeting where we will have someone presenting about helping refugees with disabilities. And that's going to be a really interesting topic as well. So if you're not already registered for that, you can jump on our website and register for that one too. And I'm just going to put this in the chat. So there's the website. You can go register for all the things and check out our other products that we have. But okay, well, I'm so grateful for everybody being here. I'm so grateful to Emmie and Rylee for this awesome presentation. I don't know about the rest of you, but I learned so much and I feel so empowered to go out and do the best work that I can do. So thank you very much for that. I'm grateful to have such powerful information to be able to share, not just here, but we'll have it online so that many, many people can learn from this. So thank you so, so much. Like I said, check out our website and I'll be sending out some emails with more resources to you all. So thank you very much.
Thanks, Mindy. Thanks, everyone. Have a great day. Bye.